Welcome to the Deep Dive. We're the show that takes complex topics, really digs in, and helps you get that aha moment. Today, we're going way beyond the surface. We're launching into, well, an extraordinary journey right into the core of what keeps you going, the integrated control of your cardiovascular system.
It's fascinating. Imagine like a world-class symphony orchestra. Every single instrument has to be perfectly tuned, playing in perfect harmony, right?
Yeah.
Responding instantly to each other, to the conductor, keeping the whole show running smoothly. That's not just a nice analogy. That is how your heart and your blood vessels work together. It's this constant, complex dance of communication and coordination. And once you start to understand it, you really see the genius of the body.
Absolutely. So our mission today is a real deep dive into the sophisticated ways your body regulates cardiac output, how much blood your heart actually pumps, and your blood pressure. We'll peel back the layers, explore how the heart and this huge network of vessels talk to each other, coordinate everything. We'll even look at extreme scenarios like intense exercise or, say, sudden blood loss to really see the body's amazing, sometimes really surprising adaptive strategies. And this isn't just about learning terms. It's about truly mastering these dynamics, understanding them like the absolute top professionals in this field. So yeah, let's get into it. Okay, starting with the bedrock concept. Cardiac output, COO. Simply put, it's the total blood your heart pumps out each minute. But what really determines this number? What are the key players?
Right, so there are four major factors here. Think of them as the main dials the body tunes. First, you've got heart rate, or HR, just the number of beats per minute, simple enough. Second is myocardial contractility. That's basically the inherent strength, the force of the heart muscle's contraction, its squeeze. Third is preload. Now, this is about the volume of blood filling the ventricles, stretching those muscle fibers right at the end of diastole, just before they contract. And it's directly tied to the pressure in your central veins, think your right atrial pressure. And finally, number four is afterload. This is the resistance the heart has to push against to get the blood out. Mainly, it's about the resistance in your peripheral blood vessels.
Okay, four factors. Heart rate, contractility, preload, afterload.
Got it.
But you highlighted a really crucial distinction earlier, separating them into strictly cardiac factors and these coupling factors. What's the big deal there? Why separate them?
Oh, it's absolutely vital. You nailed it. Heart rate and myocardial contractility, those are strictly cardiac. They're mostly controlled by nerves and hormones acting right on the heart muscle itself. But preload and afterload, those are coupling factors. And this is key. They aren't just about the heart. They deeply depend on and also influence the whole vascular system. They create this critical functional link showing the heart and vessels are constantly interacting, constantly influencing each other. You really can't understand cardiac output regulation without grasping this coupling. It's fundamental.
Okay, so to really visualize this constant conversation, this coupling between heart and vessels, our sources use these graphed curves, two types. Powerful tools, apparently.
Exactly. They help us see these dynamics. The first one is the cardiac function curve. This one beautifully shows that famous Frank-Starling relationship. Basically, it plots cardiac output against preload, that central venous pressure, or right atrial pressure. As preload goes up, meaning more blood fills the heart responds by pumping more blood out. Up to a point, of course, it reflects the heart's own intrinsic pumping capability.
So the cardiac function curve shows what the heart can do based on filling. But like you said, it's coupled to the whole system. Doesn't work alone.
Precisely. And that's where the second curve, the vascular function curve,
Right.
comes in. This one's different. It defines how central venous pressure changes because of changes in cardiac output. What's really mind-blowing here is that this relationship, it depends only on the vascular system's properties like peripheral resistance, how stretchy your arteries and veins are, your total blood volume. It's completely independent of the heart. You could literally swap in a mechanical pump, and this curve would still describe how the vessels behave. It's purely vascular dynamics.
Okay, help me picture this vascular system model. You mentioned arteries and veins being different.
Right. Imagine your circulation like a closed loop. You've got the
Right.
pump your heart, then a narrow section with lots of resistance, your microcirculation. And then these stretchy reservoirs, your arteries and veins. Now, here's the kicker. Your veins are incredibly floppy compared to your arteries, roughly 19 times more compliant, more stretchy. So think about it. To raise arterial pressure just a tiny bit, say 1 millimeter Hg, you add a little blood. But to get that same 1 millimeter Hg pressure rise in your veins, you need to add 19 times that amount of blood. They just soak it up.
19 times. That's a huge difference. So how does this play out in a normal resting state?
Well, in an average resting adult, you typically see, let's say, cardiac output around 5 liters per minute. I mean, arterial pressure might be about 102 millimeter Hg, and that central venous pressure, the preload measure, would be low, maybe 2 millimeter Hg. And crucially, in this steady state, the flow out of the heart exactly matches the flow going through those resistance vessels. Everything's in balance.
Okay, let's use this model for something extreme, like you mentioned cardiac arrest.
Yeah.
How does the vascular function curve help us understand that?
It's a powerful way to see it. So the instant the heart stops, cardiac output obviously drops to zero, but right at that moment, the blood hasn't redistributed yet. Arterial pressure is still high, venous pressure is still low. Because of that pressure difference, blood actually keeps flowing for a short time from arteries through the resistance vessels into the veins. It's driven purely by the energy that was stored in the stretched arterial walls from the last heartbeat.
Okay, that's the immediate moment. What happens next as the arrest continues? Blood keeps moving, right?
Exactly. As long as the heart isn't pumping, blood continuously shifts from the high-pressure arteries through the microcirculation into the low-pressure compliant veins. So arterial pressure keeps falling and venous pressure keeps rising. This goes on until the pressures everywhere in the system equalize. Arteries, veins, all the same pressure. At that point, flow stops completely. This final static equilibrium pressure throughout the whole system, that's what we call the mean circulatory pressure, or PMC. It's the baseline pressure when everything's still.
And given that huge 19-to-1 compliance difference, what pressure does it settle at?
Because the veins are so much stretchier, they absorb most of that shifted blood volume without their pressure rising too much. So the venous pressure might rise, say, by 5 millimeter Hg, maybe up to 7 millimeter Hg in our example, but the arterial pressure has to plummet, maybe dropping 95 millimeter Hg, to meet it at that same 7 millimeter Hg. So the PMC ends up around 7 millimeter Hg. And this value, this PMC, it really reflects two key things: your total blood volume and the overall stretchiness, the compliance of your entire vascular network.
So we can actually plot this vascular function curve using just 2 points.
Right.
The normal resting state, say, 5-limit output at 2 millimeter Hg venous pressure, and that cardiac arrest, 0.0 output at 7 millimeter Hg venous pressure.
Precisely. Those 2 points define the curve.
Yeah.
And it clearly shows this inverse relationship. The higher your cardiac output, the lower your central venous pressure, because the heart is actively pulling blood out of the venous side and pushing it into the arterial side, and vice versa. Lower output means blood backs up into the veins, raising venous pressure. For instance, if that arrested heart started pumping again, but weakly, maybe just 1 liter per minute, it would start shifting blood, and the central venous pressure would drop slightly, maybe from 7 down to 6 millimeter Hg.
It sounds like there must be a limit, though. Can the heart just keep lowering venous pressure indefinitely if it pumps harder and harder?
Good point. No, there's a physical limit. If cardiac output gets really high, so much blood gets pumped out of the veins that the pressure inside those large central veins, especially in the chest, can actually fall below the pressure outside the meambient pressure. Because veins are so floppy, this external pressure can cause them to collapse, like pinching a straw. This venous collapse physically restricts blood from getting back to the heart, no matter how forcefully the heart tries to pump. It sets a maximum limit on cardiac output that's imposed by the vascular system itself. In our model example, this happens around 7 liters per minute.
Okay, we've got the curves. Now, what things can actually change the shape or position of that vascular function curve? Let's start with blood volume.
Right. Blood volume is a major one. Remember that means circulatory pressure, the PMC. It directly reflects total blood volume and overall vascular compliance. So if you increase your blood volume, maybe through a transfusion, your PMC goes up. The whole vascular function curve shifts bodily to the right. More volume, higher baseline pressure. Conversely, if you lose blood hemorrhage, your PMC drops and the whole curve shifts left. Less volume, lower baseline pressure. It's a parallel shift.
You can see this clinically, right? Like in heart failure.
Absolutely. In acute heart failure, maybe after a heart attack, the heart pump weakens. Arterial pressure might fall, but that central venous pressure often rises as blood backs up. And that maximum possible cardiac output we talked about, it's directly tied to blood volume. If you're hypovolemic, if you've lost blood, your body's ability to reach peak output is severely limited. Interestingly, though, that critical point where veins collapse, the lowest venous pressure you can achieve, isn't really changed much by blood volume itself. That depends more on the pressure around the veins, like the pressure inside your chest cavity.
Okay, besides blood volume, what about venomotor tone? The tension in the vein walls.
Yes, venomotor tone. This is fascinating because changes in the tension of the smooth muscle in your vein walls produce effects that look almost exactly like changes in blood volume. If you increase venomotor tone, venoconstriction, it's like giving yourself an internal transfusion. The veins squeeze down, pushing blood into the central circulation. This increases PMC and shifts the curve to the right, just like adding volume. If venomotor tone decreases venodilation, it's like an internal hemorrhage. Blood pools in the relaxed veins, PMC drops, and the curve shifts left. And this matters a lot because veins hold such a huge chunk of your total blood volume. Changes in venous tone have a big impact on PMC. Changes in arteriolar tone, on the other hand, don't really affect PMC much because arterioles hold so little blood volume, maybe only 3%.
And this ties into the idea of blood reservoirs.
Exactly. Some vascular beds, like in your skin, liver, lungs, spleen, are particularly good at this. They can constrict their veins significantly, squeezing stored blood back into the main circulation when needed. Think about someone going into shock. They often look incredibly pale. That's profound venoconstriction in the skin, shunting maybe several hundred milliliters of blood away from the skin towards vital organs like the brain and heart. These reservoirs are critical for rapid adjustments.
Okay, last factor influencing the vascular curve, peripheral resistance. How does changing resistance in those tiny arterioles affect things?
Right, so changes in arteriolar tone, the main site of peripheral resistance, don't really change the mean circulatory pressure much because, again, they hold very little blood volume. So if you plot vascular function curves for different levels of peripheral resistance, they'll all actually intersect the pressure axis at the same PMC point. However, peripheral resistance does affect the slope of the curve. Central venous pressure varies inversely with resistance, assuming cardiac output stays the same. Why? Well, if resistance goes up but cardiac output is maintained, more blood has to kind of pile up in the arterial system to generate the higher pressure needed to push that same flow through the increased resistance. If total blood volume is constant, that extra arterial volume must come from the venous side. So venous volume decreases, and thus central venous pressure falls. It causes the curve to rotate, pivoting around that fixed PMC point.
Okay, we've looked at the heart curve, the vessel curve, and what shifts them. Now for the really cool part, coupling them together. Seeing how the heart and vasculature interact in real time.
This is where it all comes together. We plot both the cardiac function curve and the vascular function curve on the same set of axes. Now, there's a little graphical trick sometimes used to make them fit, maybe flipping the axis for one curve, but the core idea is the same. And where those two curves intersect, that's the system's equilibrium point, or sometimes called the operating point. This intersection isn't just a theoretical point, it represents the stable values of cardiac output and central venous pressure where the system naturally settles. It's where what the heart can pump matches what the vasculature allows to return.
And the system is always trying to get back to this point if disturbed. It's self-correcting.
Absolutely. It's dynamically stable. Imagine you suddenly inject a small amount of fluid into the venous system. This instantly raises central venous pressure, pushing the system off its equilibrium point. What happens next? Well, the cardiac function curve tells us that higher venous pressure means the heart pumps out more blood on the very next beat. That's the Frank-Starling effect. But that increased cardiac output immediately starts transferring a net amount of blood from the veins to the arteries. This transfer causes central venous pressure to fall back down. As venous pressure falls, cardiac output then decreases slightly. This back and forth happens in smaller and smaller steps, incredibly quickly, until the system finds its way right back to that unique intersection point, where cardiac output perfectly matches venous return again. Only one combination satisfies both curves.
Okay, let's apply this. What happens if we change myocardial contractility, make the heartbeat stronger, maybe with sympathetic stimulation?
Right. Increased contractility shifts the cardiac function curve upward and to the left. The heart can now pump more blood at any given preload. Now, if we assume this stimulation only affects the heart, the vascular function curve itself doesn't change. So where's the new equilibrium point? It shifts upwards and to the left, meaning you get a higher cardiac output, but counterintuitively, it happens at a lower central venous pressure. The stronger heart is just more efficient at pulling blood from the venous side. And we see this in experiments. Stimulate cardiac nerves and aortic flow, cardiac output, goes up, while atrial pressures, venous pressure, actually go down.
That really drives home why you need the coupled view. A stronger heart doesn't necessarily mean higher filling pressure. Okay, let's revisit blood volume changes using this integrated picture.
Good idea. So, changing blood volume, as we said, shifts the vascular function curve. It doesn't directly change the cardiac function curve, heart contractility. If you give a transfusion increasing volume, the vascular curve shifts right. The new intersection point with the unchanged cardiac curve will be higher and further to the right, meaning a transfusion increases both cardiac output and central venous pressure. Hemorrhage does the opposite. Vascular curve shifts left, new equilibrium is lower, and to the left, decreased CO and decreased venous pressure.
And this directly maps onto clinical scenarios like heart failure.
Exactly. Heart failure fundamentally means the heart's pumping is impaired. So the cardiac function curve always shifts downward, and to the right, less output for any given filling pressure. In acute heart failure, say right after a heart attack, blood volume hasn't changed yet. So the operating point slides down along the existing vascular function curve to a new equilibrium with lower CO and higher venous pressure. But in chronic heart failure, things get more complex. The cardiac function curve is still shifted down, but often the body tries to compensate by retaining fluid via the kidneys, which increases blood volume. This shifts the vascular function curve to the right. So the final equilibrium point in chronic failure depends on how much both curves have shifted. You'll definitely have elevated venous pressure. Cardiac output might be near normal if the failure is moderate and volume expansion helps, or it could be severely reduced in bad cases.
Okay, one more perturbation. Changes in peripheral resistance. You said this one affects both curves.
It does, making it a bit more complex to visualize. An increase in peripheral resistance, as we saw, rotates the vascular function curve, counterclockwise on the usual plots, pivoting around the PMC point. At the same time, increased resistance acts as a greater afterload for the heart. This shifts the cardiac function curve downward. The heart struggles to pump as much blood against that higher resistance. So the new equilibrium point where these shifted, rotated curves intersect will definitely show a reduced cardiac output. Whether the central venous pressure goes up or down depends subtly on the relative magnitude of the shifts in each curve. It's a delicate balance.
All right, these single pump models are incredibly useful, but you mentioned reality is a bit more complex. We have two pumps, left and right ventricles, and two circuits, systemic and pulmonary, in series.
Exactly. That two-pump model is crucial for understanding certain things. The key principle there is that over any reasonable time period, the output of the left ventricle must equal the output of the right ventricle. They're in series. If they weren't equal, blood would just pile up in either the lungs or the systemic circulation. And because the intrinsic function curves of the left and right ventricles are actually different, the left is much stronger as it pumps against higher pressure. Their filling pressures, left atrial and right atrial pressures, must be appropriately different to ensure they eject the same stroke volume beat after beat.
This becomes critically important in conditions like acute left ventricular failure, say from a blockage in a coronary artery feeding the left ventricle.
Absolutely. If the left ventricle suddenly weakens, its output drops. But the right ventricle, initially, keeps pumping normally. This mismatch means blood starts backing up behind the failing left ventricle, that is, in the pulmonary circulation. So left atrial pressure starts to rise and pulmonary venous pressure rises with it. At the same time, less blood is returning to the right atrium from the systemic circulation, so right atrial pressure tends to fall. Eventually, the system finds a new, but usually lower steady state where the outputs equalize again. But the consequence is that dangerously elevated left atrial and pulmonary venous pressure. High pressure in the pulmonary capillaries can force fluid out into the lung tissue and air sacs, causing pulmonary edema. This makes breathing difficult, reduces oxygen exchange, and can be life-threatening.
It raises a fascinating question, though. The left ventricle does the heavy lifting for the whole body. The right ventricle just pumps to the low-pressure lungs. How essential is the right ventricle? Could the left ventricle manage alone?
That's a great thought experiment explored in the literature. Imagine the right ventricle suddenly stopped pumping effectively and just became a passive tube. What would happen? Well, initially, the systemic veins and pulmonary artery would become one connected low-pressure pool. Pulmonary artery pressure would plummet. Systemic venous pressure would rise, meeting somewhere low, maybe 5 millimeter Hg. Flow through the lungs would drop drastically. The left ventricle, which was pumping fine, would suddenly get much less blood returning from the lungs. Its filling pressure, pulmonary venous pressure, would drop sharply, reducing its preload and thus its output.
So the whole system crashes. Lower cardiac output, lower arterial pressure.
Yes, overall cardiac output would drop abruptly to a much lower level, maybe half of normal. Systemic arterial pressure would fall. Pulmonary venous pressure, LV preload, would fall. Systemic venous pressure would rise. But here's the really insightful part. If you then started infusing fluid, increasing the total blood volume, you could actually restore pulmonary venous pressure back to its normal level. And if you do that, the left ventricle, with its preload restored, would pump normally again. cardiac output and systemic arterial pressure would return almost to their control values.
Wow. So the LV can handle the flow if it gets enough preload, even without the RV actively pumping. But what about that systemic venous pressure? Does it stay high?
It does.
Yeah.
Systemic venous pressure would remain abnormally elevated. Why? Because now, for blood to get from the systemic veins all the way through the passive pulmonary resistance to the left atrium, the systemic venous pressure has to be higher than the left atrial pressure by enough to overcome that pulmonary resistance. And the consequence of that chronically elevated systemic venous pressure? Fluid accumulation in the tissues edema, especially in dependent areas like the legs and ankles. This is the hallmark of clinical right heart failure. So, the principal unique function of the right ventricle isn't just pumping blood through the lungs. It's doing so while keeping systemic venous pressure low. It prevents that backup in edema that would occur if the systemic venous pressure alone had to provide the force to push blood through the lungs.
And clinically, we see this. Right heart failure, though less common, causes low output, low blood pressure, and that characteristic edema. And treatment often involves fluid infusion to boost preload.
Exactly. The models match the clinical reality quite well.
Let's switch gears slightly and talk about heart rate again. We know CO equals SVXHR. Seems simple. Faster heart, more output. But you said it's complex.
It really is. Because changing heart rate doesn't happen in isolation. It messes with the other factors too. Faster heart rate means less filling time per beat, right? So that directly reduces preload, less time in diastole. It can also indirectly affect afterload if overall CO and pressure change. And intriguingly, higher heart rates actually increase calcium influx into heart cells, which slightly boosts contractility, the Bowditch effect. So it's a mixed bag.
So if you control heart rate directly, like with atrial pacing, what relationship do you see with cardiac output?
Experiments using pacing show a really interesting pattern. As you increase the pacing rate, stroke volume steadily decreases because of that reduced filling time. That part's clear. But cardiac output, at lower rates, say going from 50 up to maybe 100 BPM, increasing the rate does increase cardiac output. The percentage increase in rate is bigger than the percentage decrease in stroke volume. So CO goes up initially.
But not indefinitely.
Right. Then you hit this plateau, maybe from 100 up to around 200 BPM, where changes in heart rate have remarkably little effect on cardiac output. In this range, the decrease in stroke volume pretty much perfectly offsets the increase in heart rate. Plus, the body's own autoregulation in tissues helps keep blood flow stable. So, CO stays fairly flat, but if you push the rate even higher, above 200 BPM, cardiac output actually starts to fall. Now, the filling time is so short that the drop in stroke volume becomes severe, outweighing the faster rate. So you get this characteristic inverted U shape for the ACO versus HR relationship.
That inverted U is important. It means simply correlating heart rate increase with cardiac output increase during exercise is too simplistic, right?
Absolutely. During exercise, yes, heart rate goes way up and cardiac output goes way up. But the pacing studies show that over a wide range, heart rate itself might not be the primary driver of the CO increase. The massive decrease in peripheral resistance in active muscles is probably a much bigger factor allowing CO to rise. So the increased heart rate during exercise is maybe better thought of as permissive. It allows the stroke volume, even if it only increases modestly, to be ejected more often, enabling the huge potential increase in CO driven by other factors like reduced afterload and maybe slightly increased contractility.
And critically, this explains why extremes of heart rate are problematic.
Definitely. Very slow rates, profound bradycardia, maybe from sick sinus syndrome or heart block, severely limit cardiac output because even with maximum filling, the rate is just too low. Stroke volume can only compensate so much, especially if the pericardium restricts filling. These patients often need pacemakers. And at the other end, extremely fast rates, tachycardia, can be equally dangerous. Filling time becomes so critically short that even a tiny bit less time causes a huge drop in filling volume and thus stroke volume. CO plummets. That's why tachycardias often require emergency treatment to slow the rate down.
We've covered the main players, but you mentioned ancillary factors too, things that influence the venous system and CO beyond the big four.
Right. The body is full of feedback loops, so it's never simple. Gravity, for example, matters because veins are floppy and blood pools. But let's focus on something we do constantly. Breathing, respiratory activity.
Just breathing in and out affects blood flow back to the heart.
It does, rhythmically. When you inhale, the pressure inside your chest decreases. This negative pressure gets transmitted to the big veins and the heart inside your chest. This creates a bigger pressure difference between the veins outside your chest and those inside, effectively sucking or pulling blood towards the heart. Venous return accelerates. You can measure flow in the vena cava increasing significantly during inspiration, though if you try to inhale really forcefully against a closed airway, a Miller maneuver, the veins just outside the chest can actually collapse because the pressure drops so low, momentarily stopping inflow.
And exhaling.
Exhaling slightly slows down the flow into the central veins. But overall, normal breathing seems to help venous return more than hinder it. The net effect over the cycle is positive. This is partly because the valves in your leg and arm veins prevent blood from flowing backwards during expiration when chest pressure rises slightly. So your respiratory muscles, combined with those venous valves, act like an auxiliary pump, boosting venous return.
And this auxiliary pump idea is really dramatic with coughing.
Oh, incredibly so. A forceful cough causes a huge, brief spike in intrathoracic pressure. This pressure squeezes the blood vessels inside the chest. Why is this useful? Well, in situations like brief ventricular fibrillation during a procedure, rhythmic coughing can actually generate enough arterial pressure to keep blood flowing to the brain and maintain consciousness for a short time.
The high pressure hits both arteries and veins in the chest. But because venous valves outside the chest prevent backflow, the pressure preferentially pushes blood forward through the arteries in the rest of the body.
But there's a downside after the coughing stops.
Yes, arterial pressure can drop quite sharply right after a bout of coughing because venous return was impeded during the high-pressure phase. Similarly, artificial ventilation with positive pressure tends to impede venous return, while negative pressure ventilation can assist it.
Okay, we've built up this complex picture of regulation. Now let's put it to the test by looking at how the system responds to major stresses, really evaluating those regulatory mechanisms. First up, exercise.
Right. Exercise is a fantastic example of integrated control. The adjustments involve both the nervous system neural factors and local chemical signals in the muscles. Neural factors include central command, that's your brain anticipating activity and activating the sympathetic nervous system. This increases heart rate, contractility, and causes some vasoconstriction. Then you have reflexes from muscle. Sensors in the working muscles detect stretch, tension, and metabolic byproducts, sending signals back to the brainstem to fine-tune heart and vessel activity. And the ever-present baroreceptor reflex is monitoring blood pressure throughout, modifying these commands.
And the local factors within the muscles.
These are crucial. As muscles work, they release substances like potassium ions, adenosine, and they become more acidic, lower pH. These act directly as powerful vasodilators, relaxing the smooth muscle on the walls of the arterioles within the working muscle.
So putting it together, what happens at the start of, say, mild or moderate exercise?
Even just thinking about exercise triggers your brain to dial back vagal nerve input to the heart and ramp up sympathetic signals. Heart rate and contractility jump up immediately, boosting cardiac output. Simultaneously, sympathetic nerves cause vasoconstriction in areas not working hard, like the gut, kidneys, inactive muscles, even the skin initially. This shunts blood towards the active muscles. Heart blood flow increases, brain flow stays constant. Skin flow is interesting. Decreases first, then increases as you heat up, then might decrease again at maximal effort.
And in those active muscles, all those local vasodilators kick in.
Massively. The resistance vessels in the working muscles dilate profoundly thanks to those metabolic signals. Blood flow to these muscles can increase 15-fold, even 20-fold. This local metabolic vasodilation is key because it dramatically decreases the overall total peripheral resistance, TPR. This lower resistance means the heart can pump out that increased cardiac output much more easily against less opposition or afterload.
What about the capillaries in those muscles?
More capillaries open up, they get recruited. This hugely increases the surface area for oxygen and nutrient exchange. Also, the pressure inside these capillaries rises a bit, pushing some fluid out into the muscle tissue. This increases tissue pressure and boosts lymph flow, which is helped along by the massaging action of the contracting muscles themselves.
And how efficiently do the muscles pull oxygen out of that massively increased blood flow?
They become incredibly efficient. The difference in oxygen content between arterial blood going in and venous blood coming out widens significantly. This is helped by the Bohr effect. Remember, in active muscle, you have more CO2, more lactic acid, higher temperature. All these things shift the oxygen-hemoglobin curve to the right, making hemoglobin release its oxygen more readily to the tissues. It's amazing muscle oxygen consumption can go up 60-fold, while blood flow might only increase 15-fold. Myoglobin in the muscle also helps shuttle oxygen.
So, summarizing the cardiac output response during exercise.
Heart rate climbs steeply with workload, driven by sympathetic nerves, eventually plateauing maybe around 180 BPM. Stroke volume, however, increases much less dramatically, maybe 10–35% in average folks, although highly trained athletes can potentially double their resting stroke volume. But the increase is much smaller proportionally than the heart rate increase.
That difference in adaptation between endurance and strength training, the cardiac hypertrophy, is interesting too.
Yes, physiological hypertrophy. Endurance athletes tend to develop larger left ventricular volumes, bigger chambers without much wall thickening. Strength athletes tend to get thicker walls with less volume increase. And critically, this healthy physiological hypertrophy is different from pathological hypertrophy caused by disease like hypertension. The healthy version involves proportional growth of blood vessels, more capillaries, wider arterioles, and no scarring or fiber disarray. It's an efficient adaptation, not a sign of strain.
So heart rate goes up a lot, stroke volume less so.
Yeah.
What's the overall role of nerves and hormones in orchestrating this?
The nervous system is key. Baroreceptors fine-tune things. Central command gets it started. Reflexes from muscles provide feedback. Hormones, especially circulating catecholamines, adrenaline, noradrenaline, are vital for reaching peak performance. Blocking their effects with beta blockers significantly limits exercise capacity by preventing the full increase in heart rate and contractility.
And getting all that extra blood back to the heart-venous return.
Several things help. Sympathetic nerves constrict veins, capacitance vessels, squeezing blood centrally. The contracting skeletal muscles act as a powerful pump, massaging blood up the deep veins, helped by one-way valves. And the increased depth and frequency of breathing acts as that respiratory pump, pulling blood towards the chest.
Does blood volume change much during exercise?
It usually decreases slightly. You lose fluid through sweat and breathing, and some fluid shifts into the active muscle tissue. But the body compensates. Fluid shifts back into the blood from inactive tissues, and the kidneys conserve water. Crucially, central venous pressure usually stays pretty constant during moderate exercise. This means the Frank Starling mechanism isn't the main driver of the increased stroke volume. Heart size might even slightly decrease as it pumps more efficiently.
And arterial pressure. With all that vasodilation in muscles, does it drop?
You'd think so, but no. Arterial pressure, especially systolic, actually increases during exercise. Why? Because the massive increase in cardiac output outweighs the decrease in total peripheral resistance. Main pressure rises only slightly, but systolic pressure and pulse pressure go up significantly due to the larger stroke volume being ejected forcefully. Vasoconstriction in the non-active areas also helps prop up the pressure.
Okay, that's moderate exercise. What happens when you push into severe exhaustive exercise, when the system starts to break down?
Yeah, compensation starts to fail, heart rate hits its max, stroke volume plateaus or even falls, blood pressure might start to drop, dehydration becomes significant. A critical point is thermoregulation. Eventually, the body prioritizes core pressure over cooling, so sympathetic vasoconstriction clamps down on skin blood flow, reducing heat loss. Body temperature can soar dangerously high. Acidosis develops as lactic acid builds up faster than it can be cleared and CO2 production is high. This falling pH depresses heart function, makes vessels less responsive, and contributes to fatigue. Ultimately, exercise tolerance is limited by muscle pain, profound exhaustion, and just the inability to will yourself to continue.
So what is the ultimate limiting factor for exercise performance? Is it the muscle's ability to use oxygen or the cardiovascular system's capacity to deliver it?
The evidence strongly points towards oxygen delivery as the main bottleneck. The lungs do a fantastic job of oxygenating blood, even at peak exercise. So it's not oxygen uptake in the lungs, it's getting that oxygenated blood to the muscles. This limitation in blood flow boils down to the pumping capacity of the heart. Specifically, cardiac output hits a ceiling, primarily because stroke volume reaches its limit before the muscles reach their absolute maximum oxygen consumption potential. The heart pump is the rate-limiting step.
And physical training improves this whole system.
Dramatically. Training increases the cardiovascular system's capacity to deliver oxygen and enhances the muscle's ability to use it. Maximal oxygen consumption increases. Trained individuals have lower resting heart rates, larger stroke volumes, and often lower peripheral resistance. Their max heart rate is similar, but they achieve it at much higher workloads. Muscles adapt too. Better vascularization, more mitochondria, more oxidative enzymes, more myoglobin. They become much more efficient at using fuel and oxygen.
Okay, let's shift to our second major stress, hemorrhage, or significant blood loss. What are the immediate signs that the system is failing?
It's usually pretty clear. You see falling arterial pressure, systolic, diastolic, and pulse pressure all drop. The pulse feels rapid but weak, sometimes described as thready. Veins on the skin, like the back of the hand, collapse and are slow to refill if you press on them. The skin often looks pale, feels cool and clammy, maybe even slightly bluish, cyanotic, all signs of inadequate tissue perfusion.
How does arterial pressure typically behave after a significant hemorrhage? Does it just keep falling?
Not always immediately. A small loss, maybe 10%, is usually handled well by compensation, with little pressure drop. But if you lose a lot of blood quickly, enough to drop pressure significantly, say down to 50 millimeter Hg, the course can diverge. Some people show spontaneous recovery, their compensatory mechanisms kick in strongly, and pressure gradually returns towards normal over hours. Curve A, let's say. Others, unfortunately, after maybe a brief stabilization, enter a downward spiral. Pressure starts falling again faster and faster until death. This is hemorrhagic shock. Curve B, and there's a critical point of no return. Once deterioration goes too far, the shock becomes irreversible. Even aggressive treatment like transfusions might only provide temporary help before the system collapses.
So the body fights back hard initially. Let's talk about those compensatory negative feedback mechanisms that try to restore pressure.
Absolutely. First and foremost are the baroreceptor reflexes. The drop in arterial pressure and pulse pressure means less stretch on the baroreceptors in the carotid sinuses and aortic arch. This triggers an immediate, powerful response. Less vagal activity, much more sympathetic activity. Result: increased heart rate, increased myocardial contractility, widespread venoconstriction, which squeezes blood out of reservoirs, skin, liver, lungs, like an internal transfusion, sometimes called autotransfusion, and generalized arteriolar constriction. This increases total peripheral resistance, which is crucial for minimizing the pressure drop caused by the reduced cardiac output. These reflexes are incredibly effective and fast.
And blood flow gets redirected?
Yes. Overall, cardiac output is down, but the body prioritizes. Vasoconstriction is less pronounced in the vessels supplying the brain and the heart, while it's intense in areas like the skin, kidneys especially later, and gut. Flow is shunted to vital organs. Severe prolonged constriction in the kidneys can lead to kidney failure, and lack of blood flow to the intestines can cause tissue damage and bleeding there.
What if pressure falls so low that even the baroreceptors aren't stimulated much?
Then the chemoreceptor reflexes become more important. Below about 60 millimeter Hg arterial pressure, lack of blood flow makes the chemoreceptors hypoxic. Their activation adds to the peripheral vasoconstriction and also stimulates breathing, which, as we discussed, helps venous return via the respiratory pump.
And if pressure drops even further, activating the brain's own ischemia response.
Right. Below about 40 millimeter Hg, cerebral ischemia triggers a massive sympathoadrenal surge. This is the most powerful sympathetic activation the body can muster, causing intense vasoconstriction and boosting heart contractility. Although, paradoxically, very severe ischemia can sometimes also activate vagal centers, causing bradycardia, which unfortunately makes the hypotension worse.
What about fluid shifts? Does the body try to pull fluid back into the blood vessels?
Yes, this is critical. Reabsorption of tissue fluids, or autoinfusion. The combination of low arterial pressure, arterial constriction, and low venous pressure causes capillary hydrostatic pressure to fall significantly. This shifts the balance across the capillary wall, favoring the movement of interstitial fluid back into the capillaries. It's quite rapid and can pull in a substantial amount of fluid, maybe a liter per hour, helping to restore blood volume, although it also dilutes the blood. Hormones like cortisol play a role in this fluid mobilization too.
And the body releases its own chemical vasoconstrictors.
A whole cocktail. Catecholamines, epinephrine, norepinephrine, surge from the adrenal glands, reinforcing the sympathetic nerve signals. Levels can increase 50-fold. Vasopressin ADH is released from the pituitary gland. It's a very potent vasoconstrictor, and its release is strongly stimulated by falling blood pressure detected by various receptors. And the renin-angiotensin-aldosterone system, RAS, gets activated by reduced kidney perfusion. Renin leads to the production of angiotensin II, another powerful vasoconstrictor, which also triggers aldosterone release.
Which leads to the kidneys trying to hang on to salt and water.
Exactly. Renal conservation of salt and water is the final major compensatory mechanism, triggered by vasopressin, angiotensin II, aldosterone, sympathetic nerves to the kidney, and reduced filtration pressure, GFR. All these signals tell the kidneys to drastically reduce sodium chloride and water excretion, conserving body fluid volume.
So those are the defenses. But in hemorrhagic shock, things can go wrong. These decompensatory positive feedback mechanisms start creating vicious cycles.
This is the terrifying part of shock. Positive feedback loops where the problem causes changes that make the problem even worse. If the gain of these loops is strong enough, the system spirals downwards uncontrollably.
What are some key vicious cycles?
One major one is cardiac failure. The hypotension itself reduces blood flow to the heart muscle, via the coronary arteries. This weakens the heart, depresses contractility, which reduces cardiac output further, which lowers pressure even more. A classic positive feedback loop. Also, poor perfusion of peripheral tissues leads to a buildup of vasodilator metabolites. These can override the compensatory vasoconstriction, lowering resistance and making the hypotension worse.
What about acidosis?
That's another critical one. Poor oxygen delivery forces cells into anaerobic metabolism, producing lactic acid. Kidneys can't excrete acid properly when their blood flow is low. So metabolic acidosis develops. Acidosis directly depresses heart muscle function and makes the heart and blood vessels less responsive to those vital catecholamines. This worsens hypotension and perfusion, which worsens acidosis. Another vicious cycle.
And the brain itself can contribute to the decline.
Yes, central nervous system depression. Severe lack of blood flow to the brain, ischemia, can eventually depress the brainstem centers that coordinate the compensatory responses. Plus, during severe stress and ischemia, the brain and other tissues release endogenous opioids, like endorphins. These opioids can further suppress vital cardiovascular control centers, impairing recovery. Blocking these opioids with drugs like naloxone can sometimes help in experimental shock.
And the blood itself starts behaving abnormally.
Aberrations in blood clotting are common. Initially, there's often a phase of hypercoagulability. Tiny clots, thrombi, can form throughout the microcirculation, disseminated intravascular coagulation, DIC. This consumes clotting factors and platelets. Later, this can flip to hypocoagulability. The blood can't clot properly because the factors are used up, leading to bleeding problems. It's a dangerous progression.
Finally, the body's own defense system gets impaired.
Right. Depression of the mononuclear phagocytic system, MPS. These are the macrophages, the cleanup crew. Their function gets suppressed in shock. At the same time, the gut barrier weakens due to poor blood flow, allowing bacterial endotoxins to leak from the intestines into the bloodstream. Normally, the MPS would clear these toxins, but now it can't keep up. These endotoxins trigger massive vasodilation, often via nitric oxide, and release other inflammatory mediators, profoundly worsening the shock state.
So whether someone survives hemorrhage or succumbs to irreversible shock really hinges on the net balance between all these compensatory negative feedback and decompensatory positive feedback forces.
Precisely. It's the algebraic sum of the gains. If the positive feedback loops become dominant, the system enters that irreversible downward spiral. This is why rapid and aggressive treatment, especially volume replacement with blood or fluids, is so critical to break those vicious cycles before they become overwhelming. Understanding this balance, this knife edge, is key to mastering the pathophysiology of shock.
Well, that was an incredible deep dive into the integrated control of the cardiovascular system. We've really unpacked the intricate dance between the heart and the vasculature. We explored how it adapts, sometimes heroically, to stresses like exercise and hemorrhage, driven by these complex layers of neural, hormonal, and local feedback loops.
It really is fascinating, isn't it? How the body strives for equilibrium, constantly adjusting. But it's also a stark reminder of the limits. Often, as we saw with exercise, the limit isn't just raw muscle strength, but the cardiovascular system's ultimate capacity to deliver oxygen. And in shock, it's about preventing those positive feedback loops from taking over and causing irreversible collapse.
So thinking about all this intricate regulation, what does it mean for you? Maybe just a deeper appreciation for how your body works constantly, unconsciously during something as simple as breathing or as demanding as a hard workout. Considering this incredible interplay of supply, demand, pressure, and flow, what aspect of your body's amazing self-regulating systems has sparked your curiosity to explore even further?